Narrow complex tachycardias are some of the most commonly encountered dysrhythmias in our practice. They are defined as a heartbeat greater than 100 beats per minute and a QRS complex that's less than 100 milliseconds. They typically arise at or above the level of the AV node and can have a wide range of presentations. These will vary with respect to acuity, hemodynamic compromise, and also most importantly, their management. Because of this, it's incredibly important to be able to recognize the electrocardiac manifestations of these rhythms.
This 27-year-old male complains of palpitations and shortness of breath. He denies chest pain and feels lightheaded when he stands up. He has no significant past medical history, but does report drinking a number of caffeinated drinks to keep him alert while studying for exams. He describes his palpitations as coming on abruptly, feeling as if his heart is turning over in his chest. Examination is notable for a blood pressure of 140/90. His heart rate is 150 beats per minute, and he's afebrile. His oxygenation is 96% on room air. On telemetry monitoring, you can see that he has a regular, narrow complex tachycardia that is going at 150 beats per minute.
Hi, I'm Dr. Stamer. How
Hey,
are
nice
you?
to meet you? Doing okay.
Rumor has it that you feel quite terrible today. The physical exam focuses on looking for evidence of hemodynamic compromise due to the rhythm. That will include signs of congestive heart failure or hypoperfusion. Depending on the clinical presentation, additional studies can include chest radiography, bedside echocardiography, and laboratory studies. Most importantly is the 12-lead ECG. The ECG will provide the information critical to making the diagnosis. Okay. Easy breaths with your mouth open, okay? When assessing the patient with a narrow complex tachycardia, the most important initial actions are to place the patient on telemetry and also then to order a 12-lead EKG. Then looking at the patient, you want to identify whether the patient is in distress. Are they diaphoretic? Are they complaining of chest pain? Are they having difficulty breathing? Important historical elements are to ask about recreational drug use and also comorbidities that would put them at risk for cardiovascular disease. The differential diagnosis of narrow complex tachycardias include 1. Sinus tachycardia, 2. Atrial fibrillation, 3. Atrial flutter, 4. Paroxysmal supraventricular tachycardia, 5. Orthodromic tachycardia of WPW, 6. Multifocal atrial tachycardia, and 7. Paroxysmal atrial tachycardia. Critical elements of the ECG that must be considered when interpreting the ECG of a narrow complex tachycardia are the presence of P waves, the characteristics of the P waves, including morphology, vector, and number of distinct P waves seen, the association of the P waves to the QRS complex, the ventricular rate, and importantly, the regularity of the rate. In this first example, you can see that the P waves are present. The morphology is consistent and normal in vector. 2. P waves are present. There is consistent morphology, but abnormal vector, indicating a single non-sinus focus. 3. P waves are present. There is variable morphology, and the vectors suggest multiple sites of atrial activation. 4. P waves are absent, but F waves are present. Clues to the presence of F waves are the absence of an isoelectric baseline in the inferior leads. 5. P waves are absent, and there are no F waves. This is consistent with atrial fibrillation. There are many different approaches to the ECG interpretation of the narrow complex tachycardia. I prefer an approach that starts with sorting out these rhythms based on their regularity. This neatly divides differential diagnosis into 2 distinct categories of rhythms, regular and irregular rhythms. Let's look at those narrow complex tachycardias that are regular. The first step when interpreting the electrocardiogram of a patient with a narrow complex tachycardia is to determine whether the ventricular response is regular or irregular. In this case, the ventricular response is regular. This limits the differential diagnosis to one of 4 categories. 1, a sinus tachycardia, 2, paroxysmal atrial tachycardia, 3, atrial flutter, or 4, a reentrant tachycardia. This is a regular rhythm. Now my next decision is to determine if the ventricular response rate is 145 to 155 beats per minute and constant. If the answer to this question is yes, then the most likely diagnosis is atrial flutter. This ECG is a classic presentation of atrial flutter. The F waves reflect the circular depolarization of the atrium from a conducting pathway in the inferior aspect of the right atrium. Activation of this circuit results in atrial depolarization at a rate that is typically 300 beats per minute. Because the AV node cannot conduct at this high rate, they are conducted at a 2-to-1 ratio, resulting in a ventricular response rate of roughly, but consistently, 150 beats per minute. De novo atrial flutter will typically present with a regular ventricular response rate of 150 beats per minute, reflecting the 2-to-1 conduction by the AV node. When the AV node conduction is slowed by beta blockers and calcium channel blockers, the ventricular response rate will reflect the variable conduction by the AV node in a ratio of 1-to-2, 1-to-3, 1-to-4 beats. When the response rate is slower, it is much easier to see the characteristic F waves in the inferior leads. If there are no F waves seen, then the most likely diagnosis is common AV nodal reentry tachycardia. This ECG shows a regular tachycardia without any P waves being visible. This is a classic ECG showing AV NRT. The mechanism of this rhythm is reentry using perinodal conduction pathways that conduct down the AV node, hence the narrow and normal QRS, and back up into the atrium. In fact, the atrium is being depolarized, but it usually occurs at the same time as the ventricle, due to the fact that atrial activation is retrograde from a circuit rhythm using the perinodal conduction tracks. The result is the P wave occurs at the same time as the ventricle is being depolarized, and so the resultant P wave is buried within the QRS complex and is not visible. If the P waves are clearly seen, then I look to see what the RP interval duration is. A shortened RP interval suggests that atrial activation is closely linked to ventricular activation and likely coming from the ventricle. The two rhythms in which this will be observed are common AV nodal reentrant tachycardia and orthodromic reentry tachycardia. Orthodromic tachycardia is a reentrant tachycardia that is using a bypass track to conduct an impulse from the ventricle back to the atrium. It is often indistinguishable from AVRT. One way to differentiate these two rhythms is to realize that orthodromic tachycardia often have rates that are in excess of 200 beats per minute and may be associated with ST segment depressions of greater than 2 millimeters or T-wave inversion in more than one lead. These findings are related to the rhythm itself and do not indicate myocardial ischemia. If the RP interval is normal, look to see if the P waves are upright in leads 2, 3, and AVF. These leads should be upright. If not, it suggests that atrial depolarization is not coming from the sinus node. Unifocal atrial tachycardias arise from a single site within the atrium that is not the sinus node. The P waves themselves will be distinct, but have a vector that is not normal and often a very short PR interval. In this ECG, you can clearly see the P waves, but if you're looking at leads 2, 3, and F, the vector is negative and the morphology is not typical of a sinus-generated P wave. This indicates a rhythm that is generated from a non-sinus node atrial site, which we refer to as unifocal atrial tachycardia. What happens if we get an electrocardiogram where the ventricular response is irregular? We then can narrow the differential down to 4 distinct possibilities. 1, atrial fibrillation. 2, sinus tach with PACs. 3, atrial flutter with variable block. And 4, multifocal atrial tachycardia. The next step in the decision tree is to look and see if you can see 3 distinct P-wave morphologies. If you can see 3 distinct P-wave morphologies, the diagnosis is likely to be multifocal atrial tachycardia. In this ECG, you can first see that the rhythm is a narrow complex tachycardia and it is irregular. You then look to see if there are P waves present, and in this ECG, you can see 3 distinct P wave morphologies. This supports a diagnosis of multifocal atrial tachycardia. A much more common rhythm is sinus tachycardia with frequent premature atrial contractions. In this ECG, you can see dominant P wave morphology that is the sinus-driven rhythm. The frequent PACs are of a distinct and different morphology and always occur at a shorter RR interval than the preceding beat.
If the initial inspection of the ECG determines that the rhythm is
Irregular.
but there are no clearly discernible P waves present, look to see if there are F waves visible in any of the frontal leads or V1. The presence of F waves suggests that the underlying rhythm is atrial flutter. If there are no F waves clearly seen, then the rhythm is likely to be atrial fibrillation.
This ECG shows a narrow complex tachycardia that is grossly irregular. Look for the longest RR interval to inspect the baseline for the presence of F waves. Although the baseline in atrial fibrillation varies from being completely flat to coarse fibrillatory waves, F waves have a consistent and distinct appearance that should allow you to distinguish atrial flutter from atrial fibrillation. So let's review a suggested algorithm for the diagnosis and assessment of a narrow complex tachycardia. The first step is to determine whether ventricular response is regular or irregular. If the rhythm is regular, then first ask yourself if the ventricular rate is 145 to 155 beats per minute and constant. If the answer is yes, then the rhythm is likely to be atrial flutter. If the answer is no, then look to see if you can see clear evidence of P waves. If you don't see P waves, then look to see if there are F waves in any of the frontal leads or V1. If these are not seen, the rhythm is likely to be a common AV nodal reentrant tachycardia. If F waves are present, then the rhythm is likely to be atrial flutter. If you do see P waves, then you look to see if the relationship between the R and P waves is normal. If the RP interval is unusually short, then it suggests that atrial depolarization is linked to ventricular depolarization and the rhythm is a reentrant tachycardia. By far and away, the most common reentrant tachycardia is common AV nodal reentry tachycardia. The presence of a very rapid rate and ST wave changes may provide clues to the far less common orthodromic tachycardia. If the P waves are present and the RP interval is normal, then look to see if the P wave morphology and the vector is normal. If they're not, then it suggests that the rhythm is a unifocal paroxysmal atrial tachycardia. If the P wave morphology is normal and the rate fluctuates gradually, then the rhythm is likely sinus tachycardia. The decision tree with an irregular tachycardia first begins with determining whether P waves are present. If P waves are present, then you look to see whether there are three distinct P wave morphologies. If these are present, then the diagnosis is most likely multifocal atrial tachycardia. If there are less than three P wave morphologies, the diagnosis is most likely sinus tachycardia with frequent PACs. If you do not see P waves, then you look to see if there are F waves that would distinguish atrial flutter from atrial fibrillation. The absence of F waves in an irregular tachycardia suggests a diagnosis of atrial fibrillation.